Welcome to Oncology Today, special edition, Current Management of Ovarian and Endometrial Cancer. This is medical oncologist Dr. Neil Love. I met with Dr. Shannon N Westin from the University of Texas MD Anderson Cancer Center in Houston to discuss the exciting new developments in this field. And this is a bonus to a program we actually did at the recent ASCO meeting, chaired by Dr. Westin. Conflict of interest statements can be found in the program notes, and the use of agents and treatments that are not approved may be discussed in this program, so check out the package insert information for more. To begin, I asked Dr. Westin about her current approach to upfront management of ovarian cancer. Let's start out with ovarian cancer, and of course, the topic that we've been talking about for many, many years now. Maintenance therapy, particularly PARP therapy. Let's just focus for the beginning on upfront management. Can you talk a little bit about first in terms of the broad strategy of PARP or not, and then we'll get into later which PARP. But what are some of the data that's come out over the past year that you think's had an important effect on clinical practice? And how do you think through choice of primary maintenance therapy nowadays outside of trial?
Yeah, I think that biomarkers are what matter, right? So we've kind of gone on a little bit of a pendulum here where for a while the PARP story was all about the biomarkers. And then there was a big exploration of PARP across, in all comers, across everyone. And now that pendulum's swinging back. And I think the bottom line, based on what we've seen from the Prima trials overall survival, from Solo 1's overall survival, that it's quite clear that you really need a biomarker to get true benefit from PARP inhibitors in at least upfront ovarian cancer, right? So for me, the first question is, do we have a BRCA mutation, whether that's germline or somatic? And then if not, do we have evidence of homologous recombination deficiency on the available testing that we have, which is typically looking at things like loss of heterozygosity, et cetera. So those are the two populations that seem to benefit the most from a PARP inhibitor in the maintenance setting. Now, we previously had an indication for all comers with niraparib, but that was recently withdrawn. And so now the upfront indication, that's just over the last few weeks, the upfront indication is strictly for patients that have evidence of BRCA mutation or homologous recombination deficiency in their tumor.
So let's get into both of those areas, starting out with BRCA and HRD positive. Can you talk a little bit about the various assays that are out there for HRD? This was brought up by one of the docs in the videos. Which ones you consider credible? And also, if you remember, there was also a case presented where despite a couple of attempts and plenty of tissue, they could not get an answer in terms of what the HRD status and how you think through that situation. And would you agree in general for these patients that usually PARP's going to be on the menu?
Yeah, I think I can start with that one. If we have been able to get evidence of HRD on a test, whatever the test might be, and we can certainly dig in on that a little bit, I feel very strongly that patient should get to see a PARP inhibitor, whether that's alone or in combination with bevacizumab, and we certainly can talk about my decision-making for that in a moment. I think that the good news is that it does seem that the majority of the HRD tests that are available commercially all seem, quite reasonable and fairly reproducible. I think in general, the way we test for HRD is flawed, but it's kind of the best that we have right now, right? So most of the testing looks at archival tissue. It's going to look at that tissue in a point in time. You're looking at things like loss of heterozygosity, which is the marker that the majority of the commercially available tests use. There are other tests like the Myriad test that adds large-scale state transitions and telomeric allelic imbalances and basically adds a few extra things to try to capture more evidence of homologous recombination deficiency. And arguably they may capture more. I think that it's hard to really tell because we don't have a gold standard test for which to really judge these tests against. I would argue that the gold standard is, do they get benefit from PARP or not? And so I think for me, though, if we get a positive test on one of these tests, then I'm going to give that patient a PARP because I want to give her the best chance of having benefit and of having a long-term progression-free and overall survival. Now, the test itself, it's true, it can be tricky because it does need a certain amount of tissue in order to get a successful test. And a lot of these patients are having their testing done on a core biopsy, right? So we get a diagnosis for a patient perhaps with just a core biopsy prior to neoadjuvant chemotherapy. And there's not a ton of tissue in those biopsies. And really, ideally, you're going to get, if you can, 5 to 10 passes. But a lot of us, we're not able to arrange for that with our interventional radiologists. We're not able to get that amount of tissue, which is why, our group and others have really favored utilizing laparoscopy when available and when appropriate, because you really can get a healthy bit of tissue in order to get that test. I think when you get inconclusive testing post chemo, obviously still frustrating, but to me, that gives us a sense that, wow, that patient had a great response and that tumor had a great response to chemotherapy. And that's why we don't have a lot of tumor tissue and tumor DNA to test. And in that case, to me, that's evidence of a clinical potential of homologous recombination deficiency. So I often will favor a PARP inhibitor in that type of population as well with an inconclusive test. And in fact, when you look at some of the trials in upfront ovarian cancer, the patients that have HRD unknown do quite well. And I think that really fits with that hypothesis that the tumor responded really well to treatment, likely because there's some action of homologous recombination deficiency.
So, but can you get a negative HRD test and a patient has a good response to chemo? And would it be a mistake to not use a PARP inhibitor in a patient like that?
It's a great question. I don't think we really have a good answer, but in the past with the right patient, I have been leaning towards using a PARP in that type of population because we don't have a lot of options for maintenance. And, after all of the data that's come out over the last 7, to 10 years, I'm very loath not to give some kind of maintenance strategy to a patient with upfront ovarian cancer. It makes me feel disappointed and frustrated. And so if I haven't arranged for a different type of maintenance, say like bevacizumab, I potentially might consider a PARP inhibitor. Of course, in the current with the current guidelines, that might be a little trickier, right? Because we did lose that recent FDA indication for all comers.
So, yes, bevacizumab, let's stick with, again, HRD positive and BRCA. How do you decide whether or not to incorporate Bev plus a PARP inhibitor? I guess Laprib.
Yeah, and in general, we may not even know the status for BRCA or HRD when we're making that first decision around chemotherapy with or without bevacizumab. And so for me, I'm giving the majority of my patients bevacizumab that have, stage 4 disease, bulky stage 3 disease. Really, if I'm giving neoadjuvant, I'm often giving bevacizumab unless there's some type of contraindication, for bevacizumab itself, right? So extensive bowel involvement, evidence of a bowel obstruction, anything that makes me think they might be at risk of a perforation. I do think hypertension is a relative contraindication, and typically we can get hypertension under good control in order to be able to utilize bevacizumab in that population. But there are some patients that are medically quite ill that it's a little bit more difficult to safely give. But for me, we're leaning more and more towards bevacizumab in that upfront population when we don't have a clinical trial for them.
So now we get into the interesting question of, again, in these patients, which PARP inhibitor? Can you talk a little bit about how you think it through? What are some of the data, including the PRIMA updates, that are influencing your current approach?
Yeah, I think we've not been able to see truly any clinical difference, in a head-to-head manner between the different PARP inhibitors, right? So then it comes down to of course, things like cost and what the insurance pays for and all of those things, and we work with the payers around that. But tolerability is a big issue as well. And so I think for a population that's had issues with counts, olaparib might be a little bit easier to give in the upfront setting, when we've seen some issues for patients in those first few cycles of chemotherapy. Conversely, for a patient that has like polypharmacy, they're already on a ton of medications. Niraparib, it really doesn't interact as much with other medications due to the way it's metabolized, so it can be often safer to give in those settings. And then, of course, the number of times a patient has to take a pill, right? So with olaparib, they're taking 2 pills twice daily. Typically, for niraparib, it's a series of pills once a day, so that might be a little bit easier for certain patients. So those are the types of things we work through and we discuss. In regards to the recent data, there was some concern I would say almost confusion around the way things looked with the Prima overall survival data. Of course, we've seen Solo One. They've reported their overall survival several times. They've not yet matured. We don't yet have a mature endpoint there, but we're over 7 years out, and we see a very consistent benefit with overall survival in that population. For the Prima data, it wasn't quite as clear. And some of that may be related to the population of Prima, which was a little bit more of a higher risk population, I would say. I think all ovarian cancer is high risk, but it was a higher stage. There were less patients that had been able to undergo optimal debulking. And so it could be that that population did overall just worse in general. We also know that there was probably crossover and that, when we can't keep patients from getting the appropriate targeted therapy, that you're going to see a difference in overall survival, right? If you think about when overall survival was reading out for Solo One, there weren't PARPs available, right? So patients that had BRCA mutations, patients that had HRD, they didn't have access. Whereas I think with Prima, we're seeing evidence of that crossover. And so you're not seeing as much of the overall survival benefit because a lot of the patients on the control arm ended up getting PARP. And any PARP at any time is better than no PARP at all. So I think I still believe that PARP for this population is absolutely beneficial. And I do not think that, one PARP is necessarily better than the other. My goal is to safely get patients a consistent dose of PARP, however that might look.
So I'm also curious about your thoughts about rucaparib. I mean, I know it may not be a practical issue, but just curious in terms of the data. Would you include that under this umbrella of it's kind of hard to differentiate indirectly in terms of benefits?
Yeah, I mean, we participated in the Athena trial. That, rucaparib is a very active drug. We participated in Ariel as well in the recurrent setting. So I think it's just as good of a PARP inhibitor. I think the tricky part is that it's not FDA approved. And even though it's compendium listed, when the payers look at that, they say, well, why aren't you using one of these FDA approved regimens? And so I think we are able to get a hold of drugs that are not FDA approved when they're compendium listed, but in this type of setting where there's multiple other drugs available, it's just been a little harder to kind of, frankly, practically give it. But all of that aside, if it was an available regimen for me that I could easily get paid for with my patient population, it's absolutely equivalent and it's very well tolerated. It still has the issues of twice daily time points. And I think that when you need to do dose reductions, having to give new prescriptions and things like that. So some of the practical matters aren't any better with it than they are with, say, olaparib.
One big issue in terms of at least olaparib versus niraparib is duration. I'm assuming that even in a BRCA patient, if you're going to use niraparib, I don't know how often that happens. Do you use it for 3 years?
That's a great question. I think that we see a lot of studies that are studies that are hopefully going to get up and running that are looking to maybe potentially de-escalate in these settings, right? Because really, when you talk to Katie Moore, who was the leader of the Solo One trial around the 2-year time point, she'll be honest and say, well, that's what we did. We decided we needed to stop it at some point, and there wasn't any, science or magic behind it. So, when you hear something like that, and then you look at the curves and you see really the predominant benefit, where you really see that first drop off of the curves is really in that first year to year and a half. And then the curves really truly flatten. So does that mean that potentially you can stop around that time point, like that that you're not getting any additional benefit with additional drug? I mean, my theory is yes. So for us, we are talking to patients at about 2-year time point, regardless of the PARP they're on, making it clear that we don't have data for stopping niraparib early, but kind of giving them the whole, all the information that we have in front of us. And I would say a good number of them will decide to stop at that time. But it's just like anything, there's a group of patients that want to continue on therapy. It's almost like a security blanket, right? Like, even though I don't have disease, this drug, I know it's been keeping me alive and I just don't want to stop it. And so then you work through the risks and benefits in that setting.
So a couple other questions in terms of upfront treatment. And one is the issue of addition of immunotherapy of checkpoint inhibitors. There are multiple trials that have looked at that. We saw another one at ASCO. I remember someone asking you, what's the bottom line?
Yeah, and so the trial that was reported at ASCO was the first trial, and it was kind of our last best hope, right? So we really wondered if the addition of checkpoint to chemo, to PARP, with or without bevacizumab, would truly have an impact. And the bottom line is, it really doesn't have a significant impact. We don't see a significant improvement in, progression-free survival. Overall survival is pending, but I think with the number of drugs, with the cost, with the toxicity, it's just not quite enough. Now, there is some parsing going on of patient populations and markers and such to try to determine if there's any role. But I think the bottom line answer is going to be no. And I think especially for the population that's homologous recombination proficient or HRD test negative, we really need to go in some different directions, looking at other targets, looking at ADCs, looking at other options in this population.
One other thing I just wanted to bring up, anytime we talk of solid tumors nowadays, somebody always brings up the issue of cell-free DNA, MRD assays. I see you have some research looking into that. You would think it might be interesting to look at ovarian cancer. What do we know about it? Are people ordering a test? Are you ordering it? If other people order it, do you look at it? Where do things stand?
Yeah, I mean, I think it's a little bit of a wild, wild west situation right now, at least in ovarian cancer, because we don't have a ton of data, but people, obviously can commercially order these tests. And so we're definitely seeing it come across our desks and really trying to build the plane as we're flying it, interpreting these data and understanding what to do with them. So I'll talk about kind of what we're doing in a second. I will say that we have some really interesting studies that are being led at MD Anderson and other institutions. And Amir Jaziri, one of my partners, has done a lot of great work with this in really trying to figure out how we can test for MRD. We've used laparoscopic second look laparoscopy, which, I was shocked because second look surgery had long been, we don't do that anymore. We're putting people through additional surgery for no benefit. But we've had, a number of patients where imaging is negative, CA-125 is negative, everything looks clean and clear. You look inside with a laparoscope and you find disease, sometimes visible disease, sometimes blind disease, where we just do washings and find disease. And those patients have worse overall progression-free survival. So if you can identify that MRD, you can identify a prognostic marker. Now, the question is, what do you do with it, right? So what we've tried to do is develop a series of clinical trials where if we find out somebody is second look positive, MRD positive, then they go on to get a different treatment, right? They don't go just to surveillance. They don't go on to get a standard maintenance. They go on to get another treatment to try to clear that disease. Interestingly, as part of those trials, we've also been looking at cell-free DNA and really found there's definitely going to be a population that's identified based on cell-free DNA, but unfortunately, there's a population for whom our second look positive, pathologically positive, but cell-free DNA negative. So it's not a perfect way, unfortunately, yet to find that patient population. So I think there's a huge opportunity here, and I think it's a really cool opportunity to potentially shorten the way we do drug development, right? We've often waited for survival outcomes, progression-free, overall survival obviously takes a really long time. So if you can use something like MRD positive at the completion of therapy, that's a really quick timeline. It's a really quick endpoint where you could quickly assess different therapeutic options and different interventions. So I think there's a huge potential here. We're not quite there yet in how we're identifying it, but I think we're gaining more and more details about that. Now, in regards to kind of what we're seeing in clinical practice, I've seen people use it as a surveillance technique. So patients that are either on maintenance strategies or in just pure surveillance, getting cell-free DNA, just like they would a CA-125 level. So every 3 months, every 6 months. What has been interesting to me, and I don't know the answer to yet, is when you see that first cell-free DNA trigger positive, should you start treating? Do we make an impact if we start treating them then? Or, is it just to trigger you to watch a little closer with imaging? And most people that I've seen that have had cell-free DNA come back positive, we haven't actually seen visible disease for another maybe 6 to 9 months. So you could look at that two ways, right? You've identified it early, you intervene quicker, maybe they do better. That would be awesome. We don't have those answers yet. Or are you giving a patient another 6 to 9 months off therapy, right? So by not necessarily triggering therapy. So I think it's a really interesting tool. I'm very excited because I think there's a lot of great studies going on that are hopefully going to answer some of these questions. But in practice, I've really struggled with, exactly what to do clinically because we don't have the data. And I certainly don't want to treat somebody for an additional 9 months to a year if it's not going to help them actually live longer.
So I'm going to move on in a minute to endometrial cancer, but just to pick up a couple of things in terms of recurrent ovarian cancer. And one question is about the use of PARP inhibitors in recurrent ovarian cancer, where, of course, we had some FDA issues in terms of pulling back approvals. But I'm curious, what are the situations where you would treat a patient with recurrent disease with a PARP inhibitor? And one in particular, we had this incredible case that Dr. Wilmot presented by video at that meeting of a woman. Somehow she managed to get olaparib like the day after Solo 1 was published. She took the paper, and so the patient was treated for 2 years, did great. I think she had stage 3C disease, was off all therapy, doing great for a number of years. And then, I think about a year and a half ago, recurred. She was BRCA1, I believe, and she put her back on olaparib, and she's on olaparib now. So my question is, what do you think about that scenario and any other scenarios in recurrent disease?
Yeah, I mean, I thought that case was so intriguing. And I think, for the population where you're considering PARP after PARP, I think that patient is a perfect example of who I might consider it in, right? So, it's easier to say, no to a population that has maybe a recurrence on a PARP inhibitor, right? So that feels like you're not going to get as much benefit if you just put that patient back on a different PARP inhibitor or give them chemo and then go back on a PARP. Like that doesn't seem like it's going to be as effective. It's the patients that get benefit and then are off for some period of time and then have a recurrence. That's the population I think we mostly consider. I think I would still give platinum in that setting because we have the best data for PARP after PARP as part of the AREO study, which was a study in this population where they had chemo and PARP. They ultimately had a recurrence. They got chemo again, had benefit, and then got randomized to either getting a PARP inhibitor or not. That I feel like we have at least some leg to stand on with some strong data that we can get benefit from that. With that being said, I think there are some intriguing small studies, my own as well as others, where we've looked at early phase trials and used PARP in combination with other agents like ATR inhibitors, WEE1 inhibitors, in a population that was considered PARP resistant, so had progression of disease either on or after a PARP inhibitor. And we've seen some intriguing benefit, but it's been mainly like response rate and stable disease and progression-free survival. Too soon to tell if that will be a more reasonable strategy going forward for the population for whom maybe maintenance isn't an option. But I am intrigued about kind of overcoming that PARP resistance with other agents that target the DNA damage repair pathway. As far as other situations I might consider a PARP in the recurrent setting, certainly we do, not as much anymore, but do occasionally see a patient in the recurrent setting that had an unrecognized BRCA mutation, unrecognized HRD, or maybe test negative and then ultimately tested positive, who never got PARP for maintenance in the upfront setting. I certainly would consider PARP in the second line setting for that patient, but again, would likely do it after platinum-based therapy, get that response and use it in a true maintenance setting.
So one other question, you mentioned ADCs, and of course we have mirvetuximab. We'll talk later on about T-DXd. I'm curious about there's another ADC that's targeting cadherin 6. Can you talk a little bit about what that agent is? This is another deruxtecan, reludotatug deruxtecan. Of course, we have a number of agents with the deruxtecan payload. What we know about that agent, what your thoughts are in terms of efficacy and tolerability, and where you think it's heading.
Yeah, I'm going to call it RDXD because it's much easier than the raludotatug. Yeah, so cadherin 6 is really highly expressed across a number of solid tumors, ovarian cancer being one of them, and had a really exciting phase 1 trial that demonstrated really high response rates in the 60% and almost 100% clinical benefit rate in a highly pretreated group of patients with ovarian cancer. And as far as and of course these types of data in phase 1 are always very exciting, and it has moved on to phase 2, a trial with phase 2 to 3 randomization. So if this ends up being a positive study, we hope this will lead to an approval in the disease. And I think what was really interesting about it is they did look back after treatment and looked at the expression levels of cadherin 6 and really found that the response rates were really across all comers. It didn't seem to be predictive to utilize the expression levels. So the subsequent phase 2 and 3 trials are being done in an all comers population. And those trials are actually actively enrolling right now. The phase 2 portion of it's called the Rejoice trial, is actively enrolling. So, if people have patients, they can put them on right now. The tolerability, it's been your kind of standard antibody drug conjugate tolerability. We've seen some bone marrow issues, some nausea, things like that, but it has overall been very well tolerated. No eye issues, none of the kind of unique toxicities, a little bit of diarrhea, those types of things. But overall, I think we're getting more and more comfortable, especially on the gen-onc side, with antibody drug conjugates. So I think it's a very reasonable drug to give. And I think they've done a really good job with their dose optimization. And so I think, based on the FDA's guidelines, they've really done a good job of really picking the hopefully right dose where we're going to see that activity, but also not have as much of the toxicity. So I'm pretty excited about the trial. We do have it open at MD Anderson.
So let's move over and talk about endometrial cancer. And of course, it's a huge issue there that's changed a lot over the last few years has been upfront treatment or just treatment in general, metastatic disease, MSI high or MSS stable, and of course, the introduction of PARP inhibitors. Can you kind of summarize what the major trials looked at and observed, and right now what your current approach is in this situation to patient care?
Absolutely. Yeah, so in general, these trials there was four major trials, and they all included patients with either advanced stage, typically stage 4. A few of them had versions of stage 3, mostly measurable, or recurrent endometrial cancer. They did allow prior chemotherapy, but depending on the trial, it had to be at least 6 months or 12 months prior to the recurrence. All of them randomized to the standard backbone of paclitaxel and carboplatin chemotherapy, with or without an immunotherapy. And the different checkpoint inhibitors that were explored included pembrolizumab, durvalumab, and dostarlimab, as well as atezolizumab. Now, I think the best way to kind of look at the data and how we use it in a clinical setting is to break it up based on the molecular testing. So, of course, mismatch repair testing is the most important piece to understanding whether or not immunotherapy will have the biggest impact. And certainly for the group that's mismatch repair deficient, it's clear that adding a checkpoint inhibitor is a clear benefit with both progression-free and overall survival. And again, we saw that across all of the studies. And we have FDA approval and European approval for these checkpoint inhibitors in this space. So the mismatch repair deficient group is a pretty straightforward group. Where we have opportunity still is the mismatch repair proficient group, which is a big group of patients, including patients with p53 mutations, patients with HER2, patients with endocrine expressing, ER and PR expressing. So I think it's hard because we've kind of lumped all of them together. We still see some benefit to the addition of checkpoint in that population to chemotherapy. It's just not as profound, right? We don't see as much benefit from the progression-free survival. We don't see as much overall survival benefit, but we do see some. The problem is that we don't know the answer to, is it better to potentially target HER2 in a mismatch repair proficient patient that has a HER2 positive tumor, right? Does that give us a bigger bang for our buck? Or in the p53 mutant group, are we better off adding a PARP inhibitor? So we saw a benefit for the addition of olaparib to durvalumab in all comers mismatch repair proficient, but really especially in that group that had either known BRCA mutations, homologous recombination deficiency, or a p53 mutation. So I think we're still trying to understand all of those things. For me, I full disclosure, I was the global principal investigator for the DUO-E study that looked at durvalumab and olaparib. I still have patients on that regimen. I mean, and this is 5 years out at this point. So to me, I believe in that regimen. And I do think there's a population in the mismatch repair proficient group that really benefits from the addition of the olaparib. So for now, I'd like to use that in all comers until I know more, and tease those populations out a little bit more. But I think overall, really exciting to have survival data in advanced and recurrent endometrial cancer, which we have never seen before. I mean, that's not since, we first started using doxorubicin. So I think that it's a really exciting time to have these different agents available.
So again, I want to ask you about a case that we presented by video from Dr. Gigi Chen, who's actually a medical oncologist who had a patient that was referred to her who was MSI high. She actually had Lynch syndrome, who had surgery for a stage 3C disease. And she followed that up with carbodocetaxel pembrolizumab, followed by pembrolizumab maintenance. And when I heard her present the case, I said to myself, that sounds kind of like adjuvant therapy. That doesn't sound exactly like metastatic disease. Where did that come from? So I started to ask people in practice, investigators, because we had this big presentation, the plenary presentation at ASCO of adjuvant IO in colorectal MSI. And I thought that was the first adjuvant trial in an MSI population. And and people were saying, oh, yeah, there were some of these patients in the Ruby trial and in the NRG trial. You guys actually have an adjuvant trial in MSI high. I think it was called the Keynote B21, chemo plus or minus IO, which is just like the plenary thing that was presented in colon. But you guys did it. It was smaller, but it was positive, as you would guess. I don't think most people know about that trial.
Well, and I think part of the problem there was that was done in an all-comers population, and the mismatch repair deficient group was a subset analysis. And so Brian
Right,
Slomowitz just
right,
published that in the JCO. And it's a small number of patients. You're exactly right, because the majority of patients that went on the study
right.
overall were mismatch repair proficient. But again, it shows very clear proof of principle. And I don't think we need to be taught this anymore, right? When we give checkpoint to mismatch repair deficient, they do better. And so I think for a lot of us, there were a few patients in Ruby that were included. There's other studies that I think are going to come out that will further support this, but I do believe that utilizing in the adjuvant setting makes a lot of sense based on the data that we have thus far.
I mean, imagine all the medical oncologists in the last 5 years who've seen patients with colon cancer and positive nodes, and they know that they would benefit, and yet they haven't been able to give it until
Yeah,
ASCO. Meanwhile, you guys have already proven it, and because it's so powerful, even though it was like 200 patients, you still saw it because you don't need a lot of patients to see that
that's
benefit.
right.
Anyhow, that was something I learned about it, and I'm glad you brought up the issue about Duo and PARP and all, because I think that's another really fascinating story. One other thing I was curious about, and again, Rutu did a fantastic talk at the meeting we had about the what was, which I guess still is, a common second line combination for MS stable patients who haven't had an IO previously. I don't know how many people are there like that anymore, but that's with lenvatinib pembro. And kind of, for years now, I've been talking to GYN investigators about how they do it, how they dose it, how they deal with tolerability. What's your formula for getting a patient through that? And what are the situations right now where you're doing it? Would you consider adding lenvatinib to a patient who's progressing after responding to an IO, for example? Or are any situations where you're using lenvatinib pembro nowadays?
Yeah, I mean it's a very powerful combination, and now we are struggling with, okay, where is the best place to use it? I think obviously in a patient population with mismatch repair proficient disease that has not yet received any immune checkpoint, that's easy, right? That's the standard of
Right.
care. We do see patients that have previously had chemo maybe, years ago, and you could potentially reconsider, a retreatment with, say, paclitaxel, carboplatin, with a checkpoint in that population based on the phase 3 studies that included that population. However, really what we saw with the LEAP-001 data, which was an upfront study of lenvatinib, pembrolizumab, versus chemo, the patient population that had already had chemo before, they seemed to be the population that benefited the most from lenvatinib and pembrolizumab. So that's a place I feel really strongly that drug should be used. Um, I'm intrigued by this idea that potentially the addition of lenvatinib can overcome resistance to checkpoint. And so we have been in very careful clinical situations adding that in to patients that are maybe on the maintenance dostarlimab or maintenance pembrolizumab, maintenance durvalumab in the frontline setting, and slowly collecting those data. We have a small case series that was presented or published by Dr. Peter Rose that looked at that and saw some pretty intriguing benefit. Now, of course, this was a patient population that had just gotten single agent checkpoint kind of in the recurrent setting for mismatch repair deficient disease. But when lenvatinib was added, they did have activity in a bulk of the patients. And so I do think there's potentially something there. I'd love to see a little bit more rigorous data around that. But until I do, I am considering that combination in that setting. But we also are balancing with other options, right? So in patients that are maybe HER2 positive and patients that have other options, we walk through those options with them. And then as far as how to get a patient through it, I mean, I definitely am a believer in starting at full dose. And I think this is where a lot of us differ. But I don't know if there's something to that idea that you want to have a loading dose and have a higher dose. So we do start the majority of our patients at 20 milligrams in my practice. And then do the dose interruptions, do the dose reductions as needed based on the side effects the patient is having. We do check in with the patients weekly, just a phone call from either the pharmacist or the nurse to check in around their symptoms and try to act as quickly as we can, and intervene as quickly as we can on any issues the patients are having. Increased blood pressure. We have them checking that at home, any nausea, diarrhea, those types of things. We try to intervene quite quickly, so that we can avoid dose interruptions and reductions if possible. For some patients, though, we do need to start at a lower dose, and that's generally going to be patients that have like a borderline performance status or already have pre-existing hypertension, anything that you think is going to be exacerbated by the lenvatinib and pembrolizumab, then I may back it down and just start at that mid-level dose, that 14 milligram dose. But I would say that's more of an exception in my practice rather than the rule.
So, and of course, at the meeting, faculty member Dr. O'Malley brought up what I've been hearing for several years, his preference for 18 milligrams. So you have different
Yeah.
size pills, makes it easier to lower. But anyhow, that's his own formula. So speaking of biomarker-driven gynecologic management, really curious what your thoughts are about selinexor. You can imagine for years now, we've been hearing about selinexor in myeloma and lymphoma. And there it's mainly how to deal with tolerability issues. And then all of a sudden, a couple of years ago, I saw this data looking at TP53 wild type and endometrial cancer. Can you kind of explain that story biologically and what we know about the potential clinical implications of using selinexor in endometrial cancer?
Absolutely. I mean, we've been eagerly anticipating results from these trials, and I really think it's a great educational opportunity around trial development, where I think that the initial trial was designed and developed in an all-comers population, obviously, because we want to try to reach as many patients as we can with these novel targeted therapies. However, based on the mechanism of action of selinexor, it really wasn't that much of a surprise when the data came out. And in fact, the population that was P53 wild type had the biggest benefit. This drug traps tumor suppressors into the nucleus. So you want an active, a fully functioning tumor suppressor. So a wild type P53 is going to help you much more than a mutant P53 as far as impacting the growth of the tumor. So I think they did a great job of looking at that subset and saying, okay, this is the population for whom really we need to utilize this drug, and this is the population that really benefits. And now they're doing the export EC trial that will hopefully confirm what was found in that initial SIENDO trial, and hopefully get us an FDA approval. And as I mentioned, when we look at mismatch repair proficient, we see some benefit for IO, but certainly the curves that have recently been presented, looking at the long-term data, I think Deb Richardson presented this at the SGO, looking at the long-term progression-free survival for patients with P53 wild-type disease that got selinexor, it is impressive. Those medians, we're seeing a quadrupling of the median over, standard of care. And so that's really exciting. So hopefully that the phase 3 trial will enroll quickly and we'll get those data, because I do think this is perhaps an incredibly impactful drug for our patients.
I'm curious whether you have any clinical experience with selinexor. Of course, again, in hematologic cancers, they started changing the dose and how often they give it, and I think it got more tolerable. But when you look at the adverse events from the SIENDO trial, it kind of looks pretty good. So, I mean, have you had any experience? I guess a lot of the GI issues is something that we heard about.
Yeah, I mean, I had the opportunity to lead a phase 1 trial combining this drug with paclitaxel, and we saw a lot of the nausea, saw a lot of the diarrhea, some of the count issues, but found when you give it at a lower dose, if you can give it intermittently, it can be quite tolerable. So I think that are benefiting from having such a long development plan, and that they've really been able to nail down the appropriate dosing for this. So hopefully it will be tolerable, because it is a big consideration with maintenance, right? If you're keeping somebody on a treatment and they have no evidence of disease, you want to make sure it's quite tolerable.
So let's finish out talking about HER2 positive gynecologic cancers, particularly advanced disease and the use of the antibody drug conjugate trastuzumab deruxtecan. Of course, there's other things we could talk about in terms of trastuzumab, but T-DXd is a new player on the block. And I've got to say, when I found out that we were going to do a program that included cases from the community looking at T-DXd and gynecologic cancers, I remember back a couple years ago when we tried to do it, we couldn't find any cases.
That's
But
right.
wow, what a difference this time. We found cases, we had people responding. It reminded me of the early days of T-DXd and breast cancer, where I start hearing these cases of these people with really interesting responses. So not saying it's the cure for gynecologic cancers, but it definitely is a powerful tool that now is in your armamentarium. So can you talk a little bit about what we know about HER2 expression in gynecologic cancers, an overview of HER2 expression, and what we know about T-DXd at this point?
Yeah, I mean, I think the early data that we had for HER2 expression was really based on the breast criteria. So for endometrial, for example, the traditional teaching was about, well, 20% to 30% of tumors will have some HER2 expression. That's predominantly going to be the uterine serous type. But now that we're using, different criteria, there's the gastric criteria, and then there's the Buddha criteria that have been looked at in endometrial cancer. It seems like it might be a bit higher, especially if you're looking at maybe 2+ and 3+, which would be the indications for the use of trastuzumab deruxtecan. I think that we're probably getting closer to 40%, maybe even 50%, depending on, again, the level of expression in endometrial cancer. For ovary, it's also a lot higher than I feel like has initially been reported. You would see things like around 5%. We're seeing much higher levels, and I'm wondering if it's closer to maybe 20-30%. And I'm really intrigued. I think there's data starting to come out now using some of these alternative testing strategies and the HER2 judging criteria, if you will, and those are finding more and more patients that qualify. Same thing with cervical cancer. We're seeing like 30-40% of patients, and so the good news is once you see that, it doesn't matter what solid tumor we're talking about. There's activity for trastuzumab deruxtecan when you have that expression. And so when we look at the Destiny pan-tumor trial that was presented by Dr. Merrick Bernstein, it's very clear whether it's cervical, ovarian, endometrial, from the gynecologic cancer standpoint, that drug is quite active in really all comers, but especially 3+, and even so 2+, where we're seeing response rates of 60%, 70%, much higher than, well, way higher than chemo, right? We're looking at 5 to 10% for chemo, but even more, higher than other targeted therapies in this same disease. And so I'm very, very excited about this drug across all of our gynecologic cancers. And I think there's a number of different studies that are moving it into the upfront setting for ovarian cancer, for endometrial cancer. So I think we're going to get some hopefully clear answers about the opportunities earlier in the treatment paradigm. But for now, we are using it in the recurrent setting as a standard of care very frequently. I have a number of patients in my practice. And just as one example, I have a lady who has recurrent endometrial cancer, 78 years old, had a really tough time with a couple of different chemotherapies prior to this, came in looking really borderline, had a mild renal injury. Her creatinine was sitting at about 2, not the hardiest person. But we started her, and, during the first few months had to support her from her, antiemetic standpoint, supported her from her kidney standpoint, gave her quite a bit of hydration. She's now on cycle 24. She pops into my office. She feels like $1,000,000. Her disease is essentially gone. She has a complete response on imaging, and she's basically been given a whole new life, is how she feels about it. So I think that it's exciting to have something like that in a population that's had multiple prior therapies, to be able to come forth with a really active drug that is tolerable is a really exciting option.
Yeah, I just had a flashback to so many times where we've been talking with T-DXd, again, people with breast cancer a few years ago. Before, I was about to ask you any patient you want to tell me about, but as usual, You just bring it up because people are so excited because they see things like that. Not that it happens to everybody, but the fact that it happens is amazing. One thing you talked about that is also interesting about getting outside of breast cancer is HER2 1 or 2 plus, when breast cancer called HER2 low. But, in breast cancer, they reflex to FISH. And if the FISH is negative, then it's considered HER2 low. If it's positive, then it's positive. But I don't see that getting done outside of breast cancer. I guess you guys don't do that.
Well, we used to for when we were using trastuzumab, especially for uterine
Right,
serous.
right,
But now with these
right.
data from trastuzumab deruxtecan, it doesn't seem like we need to. And in fact, I just had a long phone call with one of our pathologists talking about, well, when do we need to reflex? Do we need to reflex? How do you tell us? And so we're working out how we can communicate through our orders with our pathologists so they're not doing a test that we don't need.
And they didn't do it in the trial, so you really don't know
That's
what to
right.
do with it anyhow, I guess, in a way.
It doesn't seem
So
like it
final
matters.
I guess not. So, but it is interesting. It's so interesting always when you compare, different subspecialties and how they think things through. And once you get into pan-tumor approvals like the T-DXd, and that's not the only one, there are other agents out there too, that cultural difference becomes evident. So final question, you referred when you're a patient to the issue of tolerability toxicity with T-DXd. I'm curious, there's a lot of discussion, again, that start in breast in terms of acute management of nausea and vomiting. They use a lot of olanzapine. They're very aggressive. Curious what your experience is in terms of acute sort of chemo-like GI effects. And also, of course, the issue of interstitial lung disease, how often this is seen in gynecologic patients and how you screen patients. Do you do preemptive CTs of the chest even if they don't need it for their surgical staging like they do in breast cancer, for example?
Yeah, I mean, I think overall it's tolerable, but it just like we talked about with lenvatinib and pembrolizumab. I feel like in the beginning when we start trastuzumab deruxtecan, we really need to be quite aggressive in monitoring the patients and intervening when necessary. We are quite aggressive with our preemptive antiemetics, both what we give with the infusion as well as we also use olanzapine quite a bit, as well as 3-HT inhibitors. And I think those together really seem to help a lot. But again, we're checking in with patients during those first few weeks and intervening as needed. Same thing with anti-motility agents. We give them prescriptions for those agents so that they have them if they start to have any issues with diarrhea or GI upset. And that seems to really help get out in front of those issues. As far as ILD, I think with appropriate monitoring, the incidence of severe ILD can be quite low, like about 1 to 5%. But we do screen with CTs, and so we utilize CTs at the time points where we typically would be, imaging the abdomen and pelvis. We will get imaging of the chest as well, just to keep an eye for any evidence of inflammation or pneumonitis and make sure that we stop the drug at that point, and let that resolve, because we do not want to get to a symptomatic pneumonitis situation, because then that's a situation where we really aren't going to retreat with this drug. And I feel very strongly that I want to give the patient the opportunity to receive and get benefit from this drug. I do not want to have to stop it preemptively because of a toxicity.
This concludes our program. Special thanks to Dr. Westin, and thank you for listening. This is Dr. Neil Love for Oncology Today.